can't take mammograms or anything anymore. And so the only way that I could stop feeling so anxious is to get the ctDNA test. And the ctDNA test gives you a thought of what's happening 8 to 12 months before a PET CT.
Do we respect the patient enough to say, it's inexact, here's what it can tell us, and here's what it can't, and here's what it would mean, and here's what it wouldn't? Then respect the patient to make the choice.
You have to really not lie to us here. You have to tell it to us straight, be totally transparent, and then let us decide.
Hi, and welcome back to Kicking Cancer's Ass. I am thrilled and humbled to be with Amy Delson. She is a breast cancer advocate and laboratory architect. She knows her science, she knows her policies, and she knows her research. I've met her here at the Rise Up for Breast Cancer Prevention and Women's Health Conference, and I'm thrilled to have her here on Kicking Cancer's Ass. I should add that Amy is here, and she is currently in treatment for her third round of breast cancer and her fourth bout with cancer overall. So she's a veteran, and she's a badass. So we're going to hear a little bit about Amy and what she does. So welcome, Amy, to Kicking Cancer's Ass. So the first thing I want to ask is, you introduced yourself to me when we were online as I am a longtime breast cancer patient advocate. I would love for you to explain what is a breast cancer patient advocate. And I don't want you to talk about any of your clients, but you mentioned clients. And so what do you do for them? Before we get started, I want to thank Paxman for making this episode possible. When I was going through chemo at UCSF in 2023, I used Paxman's scalp cooling system, and it worked. I kept my hair when I thought I was sure I'd lose it. That mattered more than I expected it would. It's the same technology that's helped tens of thousands of cancer patients worldwide over the past 25 years. Because of Paxman's sponsorship, we can share the research and insights from the UCSF 2026 Rise Up Conference with you. So if you're facing chemo and want to explore scalp cooling, visit coldcap.com. Link will be in the show notes. Let's get back to the episode.
So basically, a breast cancer advocate advocates for the needs of breast cancer patients. And there's 3 arenas, one of which is patient-facing. So an advocate may work closely helping a patient get a second opinion, or, telling them, what are some things they can do to help them through their cancer journey. And then the second part is a research advocate, which is what I primarily do. And I work with various consortiums. I work with clinical trials like I-SPY. So this is a lot of people at this conference are part of the I-SPY clinical trial, and I work with Translational Breast Cancer Research Consortium, which is a national clinical trial group, and Komen and others, and I review for the Department of Defense for their research grants. And then the third part, which I don't do very much of, is policy. So from the research advocacy part, there's many different things that you can do there. One of them is I help young researchers. So there's a number of young researchers here. So they're going after a grant, and I might edit. Grammarly is very helpful. I might edit their, grants, and then when either the young people or the more senior people get the grant, then I'll be part of their laboratory group and meet with them, and within the grant and within those laboratory meetings, if there's something about a patient that I feel uncomfortable with, for example, we're going to do all these biopsies on the patient, I might say, well, do you really need to do all those biopsies? Or we're going to use a particular, series of drugs that's going to require the patient to come in, once a week. I might ask, well, could some of this be done locally? at their own community hospital so they don't have to go to the large hospital, or can they do some of their meetings, online so they don't need a babysitter? Because financial toxicity is a big deal.
Huge.
For patients, particularly those that don't have very good insurance, or they can't leave work. They're docked their time. They could lose their job. Who's going to watch the kids or whatever? So that's a big issue. And then so that's one part of sort of research grants, and another piece of the research grant thing is because I've been doing this for a while and I've been educated in the science of breast cancer. So a lot of the advocates here are part of a group that took something called Project Lead, which is a wonderful program where people that want to be advocates, you get a lot of homework, you have to read a lot about science and epidemiology and statistics. But since I'm talking to sort of a broad audience of people that want, I'm terrible at statistics. So it's like you get a flavor of these things, but no one expects you to either be a scientist or a bioinformatics person. But at least when somebody talks about, here's a Kaplan-Meier curve, it's not completely alien to you. And so because of that, then I was able to do these reviews for the Department of Defense, which I've been doing since 2015. And that's very interesting. Initially, I had not a clue what I was reading about, and that's, I think, true for most people. So you go to a conference or you review a grant, you understand about 10% of what people are doing. So I was in the gym, and I'd have like these videos from Stanford and elsewhere, and I'd be on the elliptical and watch these videos so I could learn about cell cycle and cellular biology or whatever this thing was. When we review as an advocate, it's not like you're supposed to understand the science. It's really how the science and the clinical trial is going to impact the patient. Again, it's very similar to what I mentioned before. We're going to give the patient this drug. We're going to give this patient AC, which is a terrible drug, and make a patient sick as a dog. And so it makes the trial slightly less, exciting, perhaps, depending on, what they intend to do for the patient. And then you also look at the impact of the trial, of the research. If I read this, is this something that's going to turn the dial? Is this going to affect my sisters, and my brothers who also get, in the world? So it's very interesting, and you review, and then you're on a panel, and so you hear different people's perspective. And what's great about the DoD and many other organizations is they really listen to what the patients say, and they say, well, I didn't actually know that. So that's going to change how I think about it. So there's a lot of respect for advocates in that way. So that's sort of the research part. So we talked a little bit about patient-facing, we talked about research, and then the third is policy, which I'm not engaged with, but there are people that will go to Sacramento or they'll go to Washington, like the NBCC people that run Project Lead. Every year they send a group to Washington, and I know people that do that, and they go on the Hill and they try to convince people that they should support breast cancer research, which these days is a very difficult thing because they don't believe in research. You should take beef tallow, perhaps, to cure your breast cancer, which is not really gonna work very well. And then also, I work in the clinical trial space as part of the research, and there, like, if I'm helping with a clinical trial, I might edit the informed consent, which is if you're going to a clinical trial, you a patient has to sign, this is what you're going to do to me, and I accept what you're doing. But the issue usually is it's very hard for the patient to understand. So we go through and make sure, A, is it written in maximum 8th grade level or perhaps 6th grade level, for depending on who the people are, because not everybody's very educated, and B, everybody's really anxious, right? Once you get diagnosed with breast cancer, you're like, your brain is mush because you're so frightened. Am I going to go to my kid's graduation? Am I going to be able to take a job? Am I going to have a quality of life ever again? So all of those things make it hard to read. So it's very important that that's clear. And then we also review the protocols. So from the research side, and then again, that's, how many biopsies, how many blood draws, how often do you take the drugs? Are you going to find out about it? Is what you're doing actually going to help some people, or are you just kind of doing it and you might be taking a drug and it's not going to help either you or, or anybody else? So that's basically the big parts and pieces.
So, Amy, is this a calling for you? And is this, are you paid by somebody, or is this volunteer? How does this work? Because it does sound like it's a passion.
It is a passion. So I'm kind of a big science wonk. In what I do is my day job, but I've always been very, very interested in the science. So I find it very interesting. But also, like many people, I am not the only one in my family who's had breast cancer. So in the generation ahead of me, many died, right? Because they didn't have mammograms. They didn't. In fact, at that point, women didn't even go to the doctor if they had found a lump or something because they were too embarrassed. You know what I mean? You didn't want to have the doctor see you without your shirt on or whatever. They had their buttons up to the top of their, neck. Many of them were immigrants. So, today probably they would have hung in, but, back in the day, maybe not so much. And they didn't know what they were doing back in the day anyway. So there's that generation. My generation, some of us have hung in, but others have died of like ovarian cancer, other kinds of things. And then I have a daughter, I have nieces, I have a granddaughter. So, I want to have a good life for them and any other woman or man in the world with this disease. So it's an exciting calling to have at this point in my life. And in terms of getting paid, I gave my talk today and everything. I didn't get paid at my hotel, got covered, but that's about it. But sometimes if you're working on a grant, you might it's encouraged to give some money to the advocate, but is it commensurate with the number of hours you put in? Not at all. And then the DOD, it might take me 40 hours, and they're certainly not paying me for 40 hours to do that. So there's little bits and pieces. Some people get more compensation than others, depending if they work for consult to a company or something like that. But I think for most people, it's really a calling, and it does take work. Although it's not, you can pick what you want to do. I work with many researchers, and like before this thing, like I was working with 6 people, in the last week. You don't have to do, you're not required. It's not like a job description. Some people do very little, and some people do quite a lot.
So when you spoke here, you were speaking, I think, about what's called ctDNA, right, which I think is circulating DNA, and the fact that you were advocating for patient choice and patient being part of the conversation. So can you do a synopsis of your talk and
Sure.
why this is the thing you spoke about? Because, and I happen to agree with you 100%, but people feel intimidated, and doctors feel protective, and I'd just love to hear your thoughts.
Let me give you like a quick synopsis. So most people have heard of DNA. DNA is what your genes are made out of. When you have a tumor, the tumor has cells. Those cells have DNA in it, and tumors shed those cells some cells will die and other things happen to those cells, and so they're shed and they end up in the blood.
Okay.
So there's a couple of ways, and that's when they're in the blood, they're called circulating tumor DNA. And they have the same little bits and pieces of genes as you have in the tumor. So that DNA is not the same as hereditary DNA. So hereditary DNA is what you've gotten from your mother and your father, and that's things like BRCA and other kinds of things like that. But this is from your tumor. And then, so it's in your blood. It's very hard to find. It's like a needle in a haystack. And so there's two ways to find it. I mean, there's more emerging, but essentially some people take the tumor and they sequence the tumor, and then they match that like a little library to the bits and pieces of DNA in your blood, mm-hmm. and that can say you probably have a tumor. You thought maybe you didn't have a tumor, but there's little pieces of tumor here from something. And so that's called circulating tumor DNA positive. If you don't have any, that's called negative. So that's one way. Another way is new tests are emerging, and they just look at a portion of your blood called the plasma, and they look at your chromosomes where the genes live, and they're little tags that are like little switches that can turn on and off genes, and they're patterns of those little switches. And they look for those patterns in the DNA. At this moment, not quite as sensitive or specific or accurate, you might say, as what's called the tumor-informed kind, but I think it's going to be the future, because not everybody has tumor that you can find. So then what does that potentially mean? So ctDNA is not just a one-shot deal, like, do you have COVID? You take the COVID test, it's positive or negative. It's so hard to find that you actually have to take it several times. So, and so if you keep being positive, that's a really bad thing for your outcome. It can mean either you're not responding to the drug that you're taking, or it could mean that you have, even though you thought all your disease was gone, maybe there's a little bit sitting out there somewhere. And then similar for negative, you can't just take one test, you have to take many tests. But the ctDNA positivity tells you a little more of a story, because it's been shown, there's some clinical trials, and more are being done. And then if you're ctDNA negative, it could mean many things. So it could mean you are, your medicine that you're taking is working. You're not resistant to it, you're responding to it. But a lot of people don't like the medicine that they're taking. So they say, well, gosh, I don't, the ctDNA is negative, I'm going to stop. But what one of the oncologists I work with, who helped me with my talk said, yeah, but if you stop and then you become positive, it may be already the horse is out of the barn or whatever, and can you do anything about it? Because now maybe you're in trouble. So there's this thing of positivity, negativity. But there's also an issue which is called clinical utility. And that means, can you act on the results? Do the doctors actually know what to do about this? So if you are ctDNA positive, can you change therapy? And people are studying that, but they don't really know, because you might change therapy and it might make you sick as a dog, because we don't know, cancer therapies are not make you feel great. But maybe it's not really a real thing. And as we just said, if you're ctDNA negative, they haven't proven that you can stop your therapy. So my talk was about, should we let the patient decide, A, do they want to get the test, and B, do they want to get the results back? And it's very controversial because most oncologists are not really believers in this yet because of the lack of clinical utility validated by clinical trials. So even really important oncologists don't believe it, but other oncologists are really think it's something real. So then what is the and part of what I talked about was, it's not a perfect test. It could the enemy of the good enough. So I interviewed a number of MD, PhD researchers, and two of them said, well, if I can explain it to my patient that it's not accurate enough yet, but maybe it could not bode well for that patient, I would work with that patient, and then I would be willing to give that patient the test. And so two of them were sort of in that camp, and another one was really, we should have, we need the validation of clinical trials, and I would explain to the patient that we don't really know what's going on. So those are those patients. And then I talked to a number of, those physicians, and then I talked to a number of patients. And some patients say, gee, I know it's not very accurate yet, it's making me nervous to even think about it. And that's what oncologists say, patients will be too nervous. But it really depends on the patient. So I talked to an African-American woman who is one of the leaders of a important African-American breast cancer group, and she said, hey, we want to know everything that we can know. We have young children at home, we have our jobs, but you have to really explain it to us really well in a way that we can understand. So, maybe somebody's not very well educated, maybe somebody is economically challenged, but that doesn't mean they shouldn't have the advantage of this, because maybe they need to know that they're really, on their way out the door so they can plan for their family or whatever. And then I myself was not with my provider, who didn't really, most community providers aren't really into this thing. I was able to get one of the people I worked in to get me the test. And so for me, I can't take mammograms or anything anymore. And so the only way that I could stop feeling so anxious is to get the ctDNA test. And the ctDNA test gives you a thought of what's happening 8 to 12 months before a PET CT. So a PET CT tells you you're metastatic. There it is in your bone. This can tell you maybe you have micromets. So maybe you could, if you caught it early enough, you could take a drug. But people are very uncomfortable. And then I had a slide about what about the community oncologist, she doesn't really know what ctDNA is. She doesn't know what test to order. What should she tell the patient? And who looks at the results? And then what is she, at the end when the results come back? What does she tell the patient when she's not sure it's positive test is actionable or a negative test means that there's no cancer? So that's another way that the advocates might be able to help, because what you really need is materials for patients, written in a very simple way with diagrams. So, most patients would understand maybe even different languages, and then one that's more sophisticated for the oncologists. So, they have a better idea. And along with the presentation I gave today, I'm giving another one to Bay Area Cancer Connections, which is a Bay Area group, which is really quite a wonderful group. And that's more, patient-facing than this one is. And I think that if the advocates work together, not something with 1 million words or something, but PowerPoint. I mean, I'm an architect, pictures are my thing. And so if we could develop something like that, so the patient could understand it a little bit and then decide, I don't want to have this test like that first patient, or, I want to talk about with my grandma. I want to talk about it with my husband. I want to talk about it with my minister, or this is what I really want to do because I'm so anxious that I want to, do something. I can't bear the sword of Damocles on my head.
Now that was great, and it sounds like the challenge is it's inexact. The science is still evolving, and do we respect the patient enough to say it's inexact, and then respect the patient to make the choice?
And be straight up. I mean, that was one of the things that the African American advocate said. You have to really not lie to us here. You have to tell it to us straight, be totally transparent, and then let us decide.
All right. I have one last question, and then we're done. And this is a quick answer. So you're a badass. You have fought this foe, and you're still out there doing science and advocating for patients in these research studies. So what's your advice to someone on how to kick cancer's ass?
So I think there are those three ways, and I'll kind of just go over them again. One of them is volunteer with a patient advocacy group. I mean, Bay Area Cancer Connection, you could be a helpliner, which means you don't have to be an expert. You can answer the phone and say, hi, you have this issue, let me pass you on to this other person. You can knit a hat for a person who's going through chemo, or do a mailer for the organization. So there's many things you can do without knowing a darn thing about science, but just caring about patients. Or take your neighbor to chemo. Make her a bowl of chicken soup, I mean, there's lots you can do as just one person to another. And then if you're interested in, working in research or on a clinical trial or want to know more, Komen has wonderful classes. So you can reach out to Komen on their website. They have opportunities to take, to learn more. It's really a great website, and maybe you can, work with them, and they actually have opportunities to send you to like a conference, which they will pay for. So I did that with them too. Or do the political side where you go lobby to your congressman and say, we don't have enough medicines for people. People are dying right and left. What can you do about it? So that's the range of things.
Great. Amy, thank you. I know this is a outside the comfort zone kind of experience for you. You were great. And I think people are going to learn so much. So thank you.